Hello, this is Nofal Anazi. I'm an interventional cardiologist at King Saud University, Riyadh, from Saudi Arabia. We'll be highlighting a few points on diagnosis and management of MINOCA, INOCA / INOCA. I have today Dr. Alaid Kifo on my right hand. She's the director of clinical research at San Raffaello Research Hospital, Milan, and Dr. Nadia Sutton, assistant professor from Vanderbilt Hospital University Medical Center. Welcome to the TCT Middle East. I'd like to start with you, Dr. Kifo. There has been a major paradigm shift in understanding and diagnosing, treating MINOCA, INOCA / INOCA. I would like you to just highlight the major paradigm shifts that we have encountered in the last few years.
So I'm an interventional cardiologist, and I was dealing with very complex clinical scenarios. So I have a big interest also in very complex PCI, TAVI, shock. But however, I was in the center of Professor Maseri, Professor Camici, and there was always all this discussion about non-obstructive coronary artery disease. So personally, I had a big interest on the topic, and when I started to be involved European Association of Percutaneous Cardiovascular Intervention, I posed the issue that indeed there was no clarity on the issue, even on diagnosis, why we don't come up with an expertus consensus document. And in fact, EAPCI came up with the Covadis group and the working group on physiopathology with an expert consensus document on, it was called initially on INOCA, and we put together all the specialists from physiopathology, and then non-invasive and invasive, trying to design a more standardized approach. Just to mention to you, this paper was published at the same time in European Journal of Neurointervention, and it was the most downloaded and discussed paper for neurointervention for years. So we were starting the movement. And then parallel, there were evidence coming. As you know, there have been the Cormica trial published showing that indeed, when you do this kind of approach, so you don't stop just with the coronary angiography, but indeed you go out, we do a coronary functional testing and vasoreactivity testing and identifying the endotype, and you give tailored therapy, this makes a difference in quality of life in angina. And we started then to insert all this topic also in acute coronary syndrome and chronic coronary syndrome guidelines. I was the task force member in both of them. And so we started with acute coronary syndrome, identify who is a MINOCA. What is this strange entity of MINOCA? So giving names, giving guidance. You cannot stop discharging someone with a diagnosis without doing an MRI, for example. If they have a schema, what you have to do. And then we moved to the CCS, and for the first time, there is a class 1B recommendation. So if you have a patient who has chest pain or equivalent, risk factor, she or he, because it's not only woman, it can be also a man disease, continue to have angina, and as an evidence on non-obstructive, you should not stop there. You must give a diagnosis, and diagnosis is with invasive coronary functional testing. And according to INOCA endotype that you can have only doing that test, you will have a diagnosis and a treatment. And by the way, you can also say to some patient that your chest pain is not cardiac. So this is how the movement went. Now we have a guidelines, and now we have to implement the guidelines. So we must do education, and we must teach also to interventional cardiology how to properly do this testing.
Thank you. Dr. Sutton, so Dr. Kifo did touch on the importance of adding coronary function test, but can you please shed the light on the yield of adding this test, and how much can it actually improve our diagnostic, conclusions before leaving the cath lab?
Absolutely, it's a great question, and much like Dr. Kifo, I think I sort of became more involved in this field because of a clinical need. And people would come to me, especially, as a female interventional cardiologist, because they had female patients that were, suspicious for having vasospasm and those kinds of things, and they needed a resource for somebody to help make that diagnosis in the cath lab. So what from studies like Carmichael and some other observational studies, for example, through Yale School of Medicine in the United States, the observation is that about 80% or more of the patients who come to the cath lab and actually undergo coronary functional testing will end up having a coronary functional disorder. And about, according to at least Carmichael, about 50% of the patients they observed had microvascular dysfunction, and then another 15 to 20% had vasospasm, and then another 15 to 20% had sort of an overlapping syndrome between vasospasm and microvascular dysfunction. And I think that, as we have both observed, we were kind of having a conversation about this, beforehand. We do think that it probably varies depending on the patient population. So I know in my practice at Vanderbilt, I've actually seen more vasospasm than I have microvascular dysfunction. And it could be because of the patients that are being referred. But ultimately, I think that we all have maybe slightly differing observations. But still, I would say that my yield is about 80% of those patients. Whereas otherwise, those patients would have come to the cath lab and either have been potentially treated presumptively, but maybe not had their therapy be honed to what the actual underlying diagnosis is, or they were told it's not your heart at all, which happens probably more often than what we would like. And then they actually have been misdiagnosed because, we don't like to, admit that, but the reality is, some patients are misdiagnosed and being told that it's not coming from your heart when in fact they were actually, having vasospasm. And in fact, if that happens, then they might actually be taken off of some of the medications that might have otherwise helped them. So it is very important to make a diagnosis.
Right. So we do know that studies have shown improvement in the quality of life, relief of angina, and some people are just happy by knowing their diagnosis, that they have a formal diagnosis. However, when it comes to hard outcomes, cardiovascular outcomes, the studies are still not very conclusive, and we're still waiting on long term. What's your take on that?
I remind all of you that actually elective PCI has a benefit only on improving symptoms and quality of life. Even elective PCI has never been proven to improve mortality unless specific scenarios, like unprotected left main or proximal LD. So we cannot expect from a non-obstructive to be different from a PCI. So the aim of all these patients is improving symptoms and quality of life in the elective setting. Another setting clearly is MINOCA, because MINOCA indeed is a myocardial infarction. So I say to these people, actually, we are achieving the same as a very complex elective PCI and quality of life and angina. These are not all patients. If we see in our casuistic, clearly it's different. I did a national study, and even the north of Italy is different from the south. Endotypes are different. It's different the metabolic syndrome of the patient, it's different the stress. There is also some, for example, pollution is acting most probably for vasospasm. So there are regional differences, and according to that regional difference, there are regional endotypes.
Thank you. So in terms of endotypes, Dr. Keiko mentioned, we do know that we're going towards endotype-tailored therapy. What can you tell us about, what is coming up and what is waiting for us in the new horizons?
Yeah. Well, I think that, first of all, I think that as we've started to learn more about this condition, I think we've expanded a bit what our endotype categories are. So, previously we were focused maybe more on microvascular dysfunction and epicardial vasospasm, but now I think we're recognizing even more nuanced categories such as endothelial dysfunction or microvascular spasm. And there's probably a lot of overlap there between some of these different disorders. And so, we had really worked hard on a publication that was published in JACC in late 2023. And we actually have it categorized by the different endotypes and what we think based off of the evidence that we have, what are the best sort of first line therapies. Oftentimes we do underutilize or under recommend potentially, real significant lifestyle modification. So weight loss, diet, exercise, those are actually really important to improve the endothelial function. And then from there, looking at things like statins and ACE inhibitors, and then depending on the specific endotype, A lot of it is some things that we already know, but when you know what the underlying diagnosis is, it gives you a better treatment pathway. So we know if a patient has vasospasm, maybe beta blockers might worsen their symptoms and sometimes, so we can remove the beta blocker if they were being treated presumptively for microvascular dysfunction. But as for therapies in the pipeline, I do think that we definitely are making progress, but we do need more therapies for our patients. Things that are being investigated currently include things like the coronary sinus reducer. Even in the United States, we're working on Pacira 2. But ultimately, I do think we do need more pharmacological options for our patients, and also to really make sure that we're doing the best we can with improving their overall cardiovascular risk factors, especially in the case of patients who have underlying metabolic disorders like diabetes and hypertension and those kinds of things.
Awesome. Thank you very much. It was a very a fruitful discussion, and hope to see you again next year in the TCT Middle East. Thank you, everyone.